you mentioned the economy being clearly the biggest issue in this campaign. And I think often people think of, the economy and healthcare being separate issues, but they're in fact not separate issues at all. I mean, we spend an enormous amount on healthcare. A lot of people's household budgets go to healthcare. So when you talk about an economic issue, health is an economic issue for people.
This is The Other 80, and I'm Claudia Williams. For the first time in decades, health is not a central issue in this election. Obviously, reproductive rights and women's health are at the top of a lot of headlines, but voters mostly care about the economy. But whether or not health is a ballot issue, how it's addressed will play out very differently in a Harris or Trump presidency. That's why I invited KFF's Larry Levitt to join me for today's episode. From reproductive health to Medicaid waiver reform, join us as we dig in just days away from the election. Please welcome Larry Levitt to The Other 80. Well, Larry, it's so great to have you on the show and wonderful to have our paths cross again. We worked together so many years ago.
More years ago than we can think about.
It was probably, I think you left the Lewin Group during Clinton health reform, if I'm not mistaken, you and Gary. So this puts us many generations of health policy
Yes.
ago. But thank you so much for joining. And obviously the election is on everybody's mind, regardless of your point of view about it. And I think one other really interesting thing for policy geeks in this election is that health is not front and center. And I'd just love to have you kind of opine about that a little bit. There are some obvious reasons for that and maybe some not so obvious reasons. So how is health playing out as a campaign issue or not this year?
Yeah, and you're right. And you mentioned the Clinton health plan. I mean, health reform has been central to presidential debates for literally decades. And this is really the first presidential election in quite some time where that has not been the case, at least until now. And I think there are a number of reasons for that. One is the Affordable Care Act seems to be stable and, in fact, thriving with record enrollment. Republicans were certainly burned politically in their effort to repeal the ACA and, for the most part, have not seemed enthusiastic about trying again. I'd say the one caveat is that could change.
Stepping away for a second from this campaign, all of us who lived through the repeal and replace, it felt like that was never going to go away as an issue, right? It just felt so permanent. Talk a little bit about how things like this shift over time. Is it just that it was popular and people don't like to, behavioral economics, nobody likes to have things taken away? Or is there something else at work that made this issue that seems so immovable change over time?
Yeah, and in many ways, we've hardly solved the problems in our healthcare system. So and healthcare is an enormous share of the economy, matters tremendously to people, both their health and their pocketbooks. So we're always going to be debating healthcare. And even though Medicare and Medicaid are decades old, we have big debates over those programs. Adding Medicare Advantage to a private plan option to Medicare, for example, or adding a drug benefit. But I think the ACA repeal debate was very different. That was not about kind of tweaking it. It was initially just repealing it outright. That evolved into a discussion about replacing it and how. And it just became this enormous, divisive, partisan debate, which felt very different from previous healthcare discussions. And I think, if we look at sort of what came out of that debate, particularly around protections for people with pre-existing conditions, I mean, those are like motherhood and apple pie now. Even Republican critics of the ACA say, they want to protect people with pre-existing conditions. They would just do it very differently.
The economy and inflation are top of mind for voters. When you intersect that with health, of course, that brings us to healthcare affordability, out-of-pocket costs, medical debt, and that set of issues. So I'd just love to have you pause for a minute on that question of affordability and go over what you see to be the campaign approaches for both the Trump campaign as well as the Harris campaign around that. And then whether you think those approaches that they're proposing, if they're proposing any, would be effective. Let's kind of dig into that question of healthcare affordability.
You mentioned the economy being clearly the biggest issue in this campaign, and I think often people think of the economy and healthcare being separate issues, but they're in fact not separate issues at all. I mean, we spend an enormous amount on healthcare. A lot of people's household budgets go to healthcare. So when you talk about an economic issue, health is an economic issue for people, and many people think about it that way. And there have been elements of that in the current campaign. The Harris campaign, in particular, has framed healthcare as an affordability and economic issue, and announced many of her proposals as part of her economic plan. So that's things like expanding the Biden-Harris administration's policy achievements on prescription drugs. The Inflation Reduction Act gave the government the authority for the first time to negotiate drug prices in Medicare. Harris wants to accelerate and expand that. The IRA also capped drug costs for Medicare beneficiaries at $2,000 a year. Harris wants to expand that to people outside Medicare. Same thing with the $35 monthly cap on insulin copays. And Harris has also talked a lot about medical debt, as you mentioned. She was a leader in the Biden-Harris administration on medical debt issues, including the effort to remove medical debt from credit reports. And she's talked about working with states to relieve people from medical debt, and a number of states and counties have already started to do that, in many cases with federal funds. It's kind of remarkable. I mean, states and counties are able to excuse people's medical debt for literally a penny on the dollar. And the reason for that is that people just can't afford to pay these bills. So the money's not going to be collected. So it really doesn't cost very much to excuse it. What that doesn't do is get to the root causes of the problem, because you can excuse people's medical debt, but then that's going to be replaced by new medical debt. And that's about the high prices of healthcare in the U.S., and it's about high out-of-pocket costs, particularly high deductibles that people face. I mean, the average deductible in an employer insurance plan now is over $1,700 per year. I wrote a piece recently calling medical debt the canary in the coal mine for healthcare affordability, and it really is. But medical debt is very symbolic of healthcare affordability problems more generally. But just dealing with medical debt doesn't necessarily solve the underlying issues.
So what about the Trump campaign? What are they saying about affordability, if anything?
Yeah, I mean, we've not seen a lot of detailed proposals from the Trump campaign. Certainly no white papers. Prescription drugs has also been a theme there. And it's interesting. We have two candidates, both Harris and Trump, who have heavily criticized the drug industry for high prices. And Trump has done that very consistently. He didn't accomplish a lot as president, but he has consistently criticized the drug industry. And he's proposed what he calls a most favored nation plan, which would mandate that the government receive the same price for drugs as other countries pay. And for brand name drugs, we typically pay to two to three times more than other countries. How that would actually work is unclear. He had a similar plan when he was president that was overturned by the courts, and that was for a limited selection of drugs, just those administered by physicians. Drugs are an easy target. The drug industry is very unpopular, and drug costs are very salient for people. And the average American fills about a dozen prescriptions per year. So the way we interact most frequently with the healthcare system is at the pharmacy counter.
One of the polls you released recently had a stat that was surprising to me. The finding was that reproductive rights and health were not a number one issue for many people in terms of their selection of a candidate. And the reason that was surprising to me is, of course, there's been a lot of press about this issue. We certainly have the legacy of what happened during the Trump administration, the Supreme Court, the Dobbs decision, other things coming out. So I'd just love to have you unpack that a little bit, and starting with, was that surprising to you as well? And how do we think about that issue playing out in the election if it's not such a core issue for many voters?
Yeah, so it didn't surprise me much just because, it's very rare to find a single issue that a voter will make a decision on a candidate based on. The vast majority of voters have already decided on a candidate because that candidate is a Republican or a Democrat. There is a core group of voters who are single issue abortion voters who will decide on based on that issue alone. And interestingly, that's evolved over time. It used to be that single issue abortion voters were anti-abortion, and they were making a decision based on that overwhelmingly. That's flipped. Now, single issue abortion voters are overwhelmingly abortion rights voters. But I don't think that issue is going to be determinative about which candidate someone votes for. But it could still have an effect on the election, particularly on turnout. And that's particularly in states that have abortion ballot measures in November. So, for example, in Arizona, there will be a measure on the ballot that may bring people to the polls who otherwise wouldn't be voting. Similarly, in Florida and a number of other states. So I think abortion could play as a turnout issue more so than on a decisive factor for which candidate people vote for. And of course, we always have to remember there's a question of how people vote, but then there's the question of what are the consequences of the vote. And there are certainly big consequences from the outcome of this election for abortion access.
It's always hard to predict what would happen under any scenario of any administration, but certainly the Comstock issue has come up for a potential Trump administration. And I'm just curious if you have seen any evidence of whether that would be on their agenda or have any predictions about that.
Yeah, I mean, if you look at Project 2025, which I think a couple months ago hardly anyone had heard of, and now it's a household term. Um, they, have called for using the Comstock Act, which is an anti-vice law from 150 years ago, to restrict abortion access. Trump has not said anything clearly. And I think what's so tricky on issues of abortion access, but lots of other issues as well, is Trump may not be very specific in the campaign, but there will be enormous pressure from who he appoints to key positions, at the FDA or HHS or CDC or in White House jobs. Pressure from members of Congress who may want to go further, pressure from outside conservative groups. And I think it's very hard to predict how that would all shake out in a Trump presidency.
That was actually one of my questions, but I wasn't sure how to frame it. As we try to look at the consequences of these votes, some of it lies in the campaign issues that are laid out, but so much of it will be what actually happens, which may or may not be. Some of the matters won't even be on the agenda at this point. I had moved away from DC when Trump was in office, but one thing that was interesting to me on some of the issues I track the closest, like health technology policy, is there were actually some pretty progressive policies coming out of CMS around some of those issues, notwithstanding an overall emphasis of the administration, which went in a very different direction. And I think one of the things somebody said in your panel this week was that personnel is policy. And so when you look at who was in key positions, they were sort of old guard-ish, right? They maybe not in the White House, but certainly at HHS, at CMS, at FDA, there was sort of an element of familiarity that probably tempered some of the other policy directions that you might have seen otherwise. Would you expect the same in this administration, or would you expect if Trump wins, and then we'll have the same set of questions for Harris, what would you expect about the personnel approach?
Yeah, with Trump, I think that's a very big question. I would not pretend to know the answer. Jennifer Young, who I had on my panel, who served in the Bush administration and in Republican jobs on the Hill, posed it as a question. I mean, would Trump appoint, kind of establishment Republicans to key jobs or people with more extreme positions and backgrounds? And I think that will influence a lot the direction of a Trump presidency if he's elected. And I think, the first Trump term was extremely chaotic. There were people in jobs who did not have a lot of experience in those jobs. They put out a lot of regulations that got overturned by the courts. There were executive orders that, didn't have a lot behind them. So I think the administration didn't get as much done as they would have hoped because of that chaos. I would expect that to be less true a second time around. I think they'd be more prepared and kind of ready to hit the ground running. And as you said, I mean, I would agree. In the first Trump term, I mean, there were a lot of very divisive actions and positions, but some, fairly common sense things that there's bipartisan support for. So, for example, price transparency in healthcare. It's been a rocky rollout. It's maybe not as effective as some of us would hope, but it was a tremendous move that people have talked about for a long time, but no one's gotten done.
And what about for Harris's potential approach?
Yeah, Harris, it's been a long time since we've had a sitting vice president be elected president. This is an even more unusual situation in that, Biden dropped out of the race and endorsed Harris. So a Harris presidency would be sort of half a continuation of the Biden Harris administration and obviously half a new administration as well. I would expect a fair amount of continuity with the current administration. Potentially some appointees continuing, which is not the norm. A lot of Harris's policy agenda is building on things that the Biden-Harris administration did, and prescription drugs, and on the Affordable Care Act. So, and a lot of her proposals are, I would say, kind of incremental and pragmatic. So I think it would feel like a pretty smooth transition from Biden to Harris.
So, Medicaid is something we talk about a lot on this podcast. And a lot of the focus for us has been looking at the waiver activity, especially around whole person care. And waivers, are used by all administrations as a way to advance policy agendas, 1115 waivers. And so I was looking with a lot of interest at some of the summaries that you've done at KFF around that. So a couple of the themes I saw both in your panel, but also in materials on the Trump side was talking about work requirements, also fraud and abuse. Another issue that's come up, but it seems a little bit less likely to really be full force policymaking, is around block granting. So all three of those, I think, tend to fit under the rubric of giving governors more tools to manage and limit enrollment, especially as a way to please governors that are less enthusiastic about Medicaid. And I'm curious if that's how you see that, and also what your interpretation of some of those policy agendas are.
Yeah, and Medicaid waivers, they're incredibly wonky, right? They rarely make headlines, but so important. I mean, it's a tool that administrations have to shift the Medicaid program without Congress, and that is so powerful. I mean, you need governors to go along. You can't, you need willing governors to do these waivers, but there often are for kind of any number of different ideas. And I think that the waivers you saw in the Trump administration and would likely see similar in another Trump administration kind of really reflect the ideological divide over Medicaid. Democrats, we'll get to what Harris might do. Democrats generally view Medicaid as a health insurance program that's a building block towards universal coverage. Republicans view Medicaid as a welfare program for the deserving poor and an out-of-control entitlement that you need to somehow control for budgetary purposes. And the waivers very much reflect that. Work requirements being a perfect example, that you've got to be working in order to deserve Medicaid, that if you're not, for whatever reason, you're not deserving of health insurance. And what's so interesting about work requirements is the vast majority of Medicaid enrollees already are working or are not working for reasons that I think most people would view as legitimate. They're caregiving, they're going to school, they're disabled. But the way work requirements work out is not that they encourage work in the end, it's that they erect administrative barriers to people enrolling. I mean, you even had a website that was where you had to report work that was only open during business hours, right? And really hard to access. So, I think we would see similar waivers in another Trump administration. At the very end of the Trump administration, we started to see the idea of kind of converting Medicaid to a block grant or a capped entitlement at state discretion. And I think that could return as well. It's particularly if you've got divided government, if the Republicans don't have a trifecta, but Trump is in the White House, waivers will be, I think, a very powerful tool.
On the Harris side, one of the intriguing questions is how do you start to extend Medicaid expansion to the 10 states that have still not selected to do that? And one option obviously is just to put honey in the pot, right? To like figure out more ways, like North Carolina, they were able to kind of convince people to get across the line. There was a lot of money on the table for that. Another is this kind of direct option that they've talked about. How viable are some of those strategies? When you talk to Democrats, I mean, they're sort of concerned that the access to this core benefit is so inequitable across the country, and that's the obvious place to start. How would you think about that?
There is. I mean, the American Rescue Plan created an additional fiscal incentive for states to expand. There's already a big incentive. The federal government pays 90% of the cost. ARPA created an additional incentive, increasing the match rate on the traditional Medicaid program, which effectively meant that for 2 years, Medicaid expansion would be free for a newly expanding state. And in fact, states would make money by expanding. I think that was instrumental in pushing North Carolina over the line and expanding. There's been discussions in Mississippi, which is, would not be at the top of your list for a state to expand. So I think that fiscal incentive will continue to play a big role. There's been this tension from the very start with Medicaid expansion of kind of how much to sweeten the pot, or how much to allow states to, particularly conservative states, to put their own stamp on expansion, whether that's a work requirement that goes along with it, or there were states wanting to partially expand just to up to 100% of poverty, and have people over 100% of poverty in the ACA marketplaces. But I think particularly for these remaining 10 states, for opponents of Medicaid expansion to support it, they need to feel like they've put some kind of conservative stamp on the program.
It's always confusing to me. Why haven't corporations and companies and businesses been more vocal about saying we need this for our state? Because it is ultimately an economic driver as well, because it allows more flexibility, allows people to switch jobs, all these things. And I think that was true in North Carolina, where the coalition of folks was sort of an unlikely set of businesses, sheriffs, counties, all of these kinds of organizations that we don't think of as being very active.
Yeah, and I really thought to begin with, once the Supreme Court made the expansion voluntary, that hospitals would be a very powerful lobbying force in states, and I think they have. It's just they have not been able to overcome some of the symbolic politics associated with Obamacare in very red states, and just legitimate concerns about the cost of Medicaid and adding to that cost.
Of course, the presidential election is occurring in a set of other elections that could determine whether the president has support from Congress or not. And so there's any number of different combinations that could come out of that. And I thought there was a really interesting discussion in your panel about what could be bipartisan, which could be legislative, or they frankly could be administrative changes that curry the favor of other parties. And some of them that were mentioned were long-term care, aging of America, and how do we think about long-term care costs, AI oversight, physician payment reform, which Chris Jennings brought up quite a bit, and the opioid epidemic, which are a very diverse set of issues. I'm just curious whether any of those are ones that you really think there's a likelihood or a chance of having some kind of bipartisan progress, and what would that look like?
Yeah, I think, for example, on addressing the opioid epidemic, we've already seen bipartisan action. For example, the Support Act. Trump, when he was president, declared a public health emergency. I think where it gets hard there is how much to emphasize access to treatment and concerns among some that somehow promotes substance use versus taking a much harder line and a law enforcement approach. So I think those tensions will emerge and make progress difficult. AI, I mean, people are going to need to deal with it, right? I mean, it's not, it's certainly not going away. So I think that's an issue. I mean, you mentioned at the top that there's some healthcare issues that we know are going to be debated. There's some that just present themselves and force action. And I think AI is in that latter category. I would add some others like price transparency. I think we'll see continued bipartisan action on that, and PBM reform. PBMs, pharmacy benefit managers, there's very interesting politics surrounding it. I mean, during the debate over the Inflation Reduction Act, which gave the government authority to negotiate drug prices in Medicare, that passed with only Democratic votes. Republicans and the pharmaceutical industry were trying to pin blame for high drug prices on PBMs. And certainly PBMs do deserve some blame there. I think Democrats were so all in on giving the government authority to negotiate drug prices and making pharma the boogeyman, that they were not going to go along at that point to anything addressing PBMs. Once the Inflation Reduction Act passed, I think it opened the door to more bipartisan action on PBMs. And I think we could very well see that in the next year.
What is the sleeper issue that you're focused on that you think isn't getting as much attention as it should?
Well, I'll mention two, one of which we talked some about. First is healthcare affordability, particularly for people with employer-sponsored insurance. We focus so much on Medicaid, Medicare, the ACA. Still, the biggest source of coverage for people is employer-sponsored insurance. And there are huge affordability issues there, particularly for low-wage workers. It's great that a low-wage worker has access to employer health benefits, but if it's a several $1,000 deductible, that's often going to feel like no insurance at all. And we just have not talked about that enough. What are the policy levers to try to improve affordability in employer-based insurance? The second one is one you mentioned, which is long-term care. Our population continues to age. The needs for long-term care are going to continue to grow. There are so many tentacles to this issue. I mean, we have a shortage in the workforce for both institutional and home-based long-term care. The demand for home-based long-term care has increased since COVID, when people are more hesitant to get institutional care. We rely so much on immigrants for this workforce, and restrictions on visas, restrictions on immigration make that harder. And it's all just expensive. I mean, it is how to pay for it is an enormous challenge, but that problem is certainly not going away.
One of the things I've been puzzling over is I see a huge opportunity and need for more innovation and more innovative companies in Medicaid. So spend a fair amount of time talking to investors and companies, hearing about all the challenges of dealing with 50 states and all of that. If you were not in the news business, if you were in the investment business and you were looking at this election and trying to predict what markets would be interesting or lucrative, what would be your predictions of the economic opportunity created by the two administrations?
The kind of companies we see attracted to Medicaid are, for example, the consulting companies that build big eligibility systems or claims payment systems for Medicaid. But we don't see, and I would turn it around to ask you, but we don't see a lot of companies innovating in how to better serve low-income populations. How do you make the eligibility system simpler? How do you manage care for low-income people? What are the opportunities for AI for that population? And, I think there's just this perception in the business community that, well, low-income people don't have a lot of money, right? So that's not a business opportunity. But when you've got programs like Medicaid, which are enormous, there is a lot of money in those programs. It may not be money out of people's pockets. There are business opportunities to serve that population better.
So, looking at the largest states that are doing the most innovating in care delivery, typically they're doing that through managed care. Not always, but typically. So really, the buyer is the managed care company. And what I hear a lot from companies is with reimbursement rates low, they need to have some upside for the dollar saved, for the value created, for the health outcomes. While we have some really replicable models in Medicare, around ACOs and things like that, I think there's been a lack of standardization of value models in a world where you're moving towards complex care coordination that would allow a company to help improve the health of the member and get some benefit from that. And some of that's because each managed care company is operating under the rules of its state and have limitations there. I think we'll see it eventually, but because those companies require so much money at the front end, I think it's a deterrent on investors because they're like, that's complicated. I mean, Andy Slavitt aside, who would say like everybody should invest in that. But I think especially as Medicare Advantage has become less lucrative and less interesting, and then I think people also who try to go after the commercial market quickly realize that in a model where they're self-insured and the health insurance companies just a pass through, like nobody's at the other end of the line willing to innovate. Essentially, there's nobody you can turn to. Commercial's hard because there's nowhere you can turn. Nobody's going to be your partner in that. Medicare's less lucrative, and so I think you end up having to look at Medicaid. A lot of the more promising models rely on a new workforce that frankly hasn't quite built itself up yet, whether those are doulas or community health workers or peer educators. And so you have these really exciting models, but you're like, oh, where are the people? Like, and they,
Right.
talk to people in different states and they're like, we have 10 people that are awesome and they keep on moving from plan to plan as they get, a little bit more money. And so I also think we just have a workforce capacity issue because a lot of the models that are developing really rely on this workforce that hasn't been trained, hasn't been developed as of yet.
Absolutely, and some of these jobs don't have obvious career paths as well. I mean, you look at, for example, direct care workers in long term care. What is the career path for someone who wants to advance in that as a profession? Are there the training opportunities, the mentorship opportunities?
I've learned that if I put the word COVID in an episode title, nobody listens, which is very depressing. It's been a really weird campaign issue because nobody really wants to talk about it. Everybody wants to be done and over with it. But I do think this is an area where we would be likely to see very different approaches, both in terms of funding and infrastructure, in the two administrations. So let's spend just a minute on this topic. What are you seeing in the two campaigns, if anything, around this? And what would you expect to be the differing approaches of the two administrations?
In a Trump administration, we would see continued vaccine skepticism, continued skepticism of science generally, and I think certainly not a desire to prepare for another pandemic. We would not see that approach in a Harris administration, but I think it'll still be a hard sell to put a lot of resources into pandemic preparedness. That's just not where the country is. We've reverted to historical patterns of, you bring resources to a crisis, but once the crisis is over, we go back to not thinking much about public health.
Sad. You focus a lot on the presidential election and the U.S. government, the federal government. I'm curious what you see at the state level. What are some ballot initiatives that are worth really people paying attention to?
I mean, certainly the abortion ballot measures are big ones, and every time abortion rights has been on the ballot, it has won at the state level. That my guess is will continue this time, with the possible exception of Florida, where it has a 60% margin to pass. If all these measures pass, it could really reshape abortion access in many parts of the country, or the opposite could certainly be true. And I think what we've seen, particularly with abortion, is that all kinds of other political races that no one ever really paid a lot of attention to matter as well. So, for example, Supreme Court justices who are elected in some states, attorneys general matter enormously. Certainly, the control of state legislatures matters a lot as well. When you look at Medicaid expansion, it's not on the ballot. And there are very few remaining states that could put it on the ballot that have not expanded. But again, governors' races, control of state legislatures matter a lot in terms of the prospects for states to expand.
You play a really unique and important role, I think, in educating both very in the know people, but also the general public about what's at stake for health in politics. What are you hopeful about? And what are you discouraged about as we enter the final stages of this election cycle?
So hopeful that there's been progress on some very tangible issues. So, for example, capping insulin copays at $35 a month in Medicare, and I think it's a really good example of what can work well in health policy. We so often deal with incredibly complex issues that are impossible to explain, that have trade-offs and winners and losers, and people's eyes just glaze over. $35 insulin is very tangible to people. It doesn't affect everyone, though it does affect millions of people, but it's just something people can get their arms around. And it's a signal that we're doing something to make healthcare more affordable for you. So, I think a challenge for health policy advocates on all sides of issue is to find ways to make these issues understandable and tangible to people. Because too often, instead, what we do is just make them more complicated and impossible for people to digest.
I just want to say just such profound thanks to you and to your team and to the work that your organization has been doing over many years, especially in a world where there aren't always the best business models for good news. Having the kind of investment you're making makes a huge difference to all of us. So thank you for that.
Well, thank you. I think we're an unusual organization in that we're not advocates. We don't lobby. We combine policy research, news, and polling, which is very unusual. In what has become a very, very divisive partisan environment, it's continually a challenge to kind of maintain our role.
Bear with me here as I read you a list of health issues that are not being discussed in any real way this election season. Paid family leave, maternal mortality, expanding Medicaid, access to food and housing, mental health, healthcare affordability, and long-term care, with the possible exception of Harris's recent proposal. And so whatever the result on November 5th, we need to keep the conversation moving ahead so that health doesn't get left behind as our new president seeks to fulfill their election promises. Promises that, this time around, largely ignored health altogether. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Larry Levitt and his work with KFF. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.